to invite Linda to turn on her video. Hello, Linda.
Hi, good morning.
So Linda, I'm going to invite you to introduce yourself and to tell us a little bit about your personal experience. Thank you very much.
Thank you. Right, so my name's Linda, and I have suffered throughout my life with personality disorders. And the personality disorders is all these emotions, the feelings that I didn't understand what they were. And they kept sort of overwhelming me to the point that I have to take a break from all these emotions that keep coming into the mind. So it was always, I'd get frustrated because I couldn't explain what these emotions and feelings were. And it started off in my teenage years with me going to A&E because I'd be punching walls and breaking bones in my fingers, because I just needed something to stop all these feelings. And when you're doing something like that, it does stop those feelings for a period of time before they all start overwhelming you again. And as I moved on in life and sort of went into my 20s and that, it started with overdosing. And it would just be loads of tablets. Sometimes there would be alcohol. And it was just because I couldn't cope with all these emotions and feelings that were coming into my mind. And I'd end up in hospital, I'd end up unconscious for days, coming round afterwards. And out of all of the times that I did take overdoses, there were some of the times that it was to kill myself because I couldn't cope with life anymore. I couldn't cope with these feelings. I had such a low self-esteem that I thought I was useless. I was, nobody cared about me. Nobody wanted to know about me. I couldn't do things properly. I was just never in the right frame of mind to be able to sort things out myself. So I was very, very low on my self-esteem. And, that would cause me to take even a load more tablets. And fortunately for me, it didn't work because I'm sitting here today talking to you. But there's been other times where it's been even worse, where I've been at a railway station and I've actually jumped off the platform, but somebody's grabbed me from behind and pulled me back. And I think, when something like that happens, people don't understand why somebody is doing something like that, why somebody wants to, kill themselves and be out of this life. And people don't understand that what is going through your mind, all these feelings and the self-doubt about yourself. And nobody understands that. So you get a lot of people that think, oh, here we go. That could have caused a long train delay, or here we go, she's back in hospital again. It's a total waste of money, total waste of NHS time. And I've had it all, going into hospital and having the nurses think, oh God, here she is again. And that went on and on and on for years. And of course, that made me feel even worse within myself. It made me feel then that, again, nobody cared. Nobody wanted to know why I felt like I did. I couldn't explain to them why I felt like I did. So I felt like nobody was interested in getting to know me and trying to help me discover what the emotions were I was feeling, or even to help with another outlet rather than doing something that, can be really dangerous. It could have been death by misadventure, which means that, one of those overdoses could have killed me. And I wasn't thinking of suicide that particular time. People get it really wrong, thinking that, you know, you are a time waster. And now that I'm working on the other side and I work within a crisis team, I've seen from myself what it does to people. And I find that what I would have liked is maybe somebody to sit here beside me and to say, look, everything's going to be all right, you know, and had the time to listen, to maybe help me find the emotions and feelings that I didn't know what they were or what they are. And, you know, it would have been really nice. I've had people sort of look down at me and you know, I'm such a terrible person, and why the hell have you done that? And it's all about the language as well that you would speak to somebody with, because somebody turning around and saying, why the hell have you done that? Oh, well, you only took that amount. It makes you think, right, I'm going to take a lot more next time because I've only taken that amount. So having somebody sit beside you and being able to say to you, and that's what I do as a peer support worker. I sit beside somebody, I acknowledge the feelings, you know, I validate the feelings, because we've got these feelings. We need somebody to validate them and say, right, that must be really awful. Let's try and work out how we can change those feelings. Let's work out what those feelings are. You know, let's work out how we can change and get you to do something else that is, you know, much more productive than what you're trying to do. So I just feel that, you know, these days it is changing, attitudes are changing, and people are sitting next to somebody rather than looking down at somebody. And people are changing their language, but it is really slow. And that is one of the reasons that I became a peer support worker and working with the crisis team, is that I can put my knowledge to the staff and to use it towards the patients that I see that are in crisis at the time. So that is just sort of like a whistle stop conversation on me and how life has been for me. Unfortunately, I have been able to find, you know, what those emotions are and been able to turn my life around. And that proves that everybody else can as well, if they have the right person sitting beside them. So thank you.
Linda, thank you so much. I just, that a really powerful description of movement and you know, of life changing, and it not having to stay as hard and as difficult it was, and equally sort of that description of the things not to say, you know, that actually, you know, if somebody is self-harming or indeed wants to take their own life, that actually they need people to acknowledge where they are and what they feel, and not to dismiss or look down on. So thank you so much for that very frank and honest description of how it's been for you. Thank you. I'm just going to invite Claire now to speak. Linda, if you could turn your video off, and Claire, turn hers on.
Hello.
Hello, Claire. Thank you so much for joining us. As I mentioned, Claire is the mum of James, who took his own life a number of years ago. And we're very grateful that you're going to come and tell us a little bit about how that's been, and some of the things that perhaps people need to take into account when they're talking to somebody who's been in your situation.
Okay, thank you. Thank you, Sean and thank you, Lucy, for inviting me on this. And thank you to everyone who has come to listen today. And I just want to say, Linda, that was a very, very brave and very honest account of your struggles. So thank you for sharing that with all of us. So yes, my name is Clare Milford Haven, and I am the founder of James's Place, and I'm James's mum. And I'd like to tell you a bit about the background. Next slide, please. So this is James, and James was my eldest son and much loved son, grandson, cousin, brother, friend to everyone. We never had a day in our lives when we were concerned about James or James's mental health. However, when he was 21 and a student in his second year at Newcastle University, he said that he wanted to have a minor operation, and on one of his testicles, was something that bothered him. He had something called a varicocele, and he wanted it to be corrected. And I said that it was his body. He was now over the age of 18, and he could make those decisions for himself if he felt this was something he wanted to do. And it clearly was. So I supported him in his decision, and he went off to have this operation at the beginning of December in 2006. He had the operation in London on December the 4th, 2006. And after the operation, he became extremely anxious about the outcome of the operation. He believed wrongly that he had been made impotent, and he believed, I just feel he felt he'd been sort of castrated in some way. James was quite an impulsive, impatient young man. I mean, he was everything to me. He was fun, he was bright, he was sporty, popular, all the things that I would want in my son. But he became fixated on this operation and its outcome. And I did the best I could to reassure him. But he sought help up in Newcastle. He went to a walk-in centre and he told them how he felt. He told them that he felt suicidal. And unfortunately, they made him a very low priority and sent him to A&E, where on his own, despite saying he felt suicidal. And after a 2-hour wait, he walked out. At the walk-in centre, they wrote down my GP's number, but they never called him. And they sent the form to my GP and James's GP, which arrived 10 days after James had died. So I believe that James didn't want to die. I believe that the fact that he sought help was an indication that he actually didn't want to end his life. But he couldn't find the help that he needed so badly. He couldn't find the right help. And actually, as Linda was saying earlier, he just needed somebody to sit with him and listen to him and spend that time with him while he was in crisis. So as a result of James's death, 10 days after the operation, we had no time to understand what was going on with James. We had no experience of mental health problems, no experience of suicide. And I'm not going to go into more detail about what happened with James, but I'm just going to say that as a result of his death, we decided that we wished to create a fund, a foundation in James's memory. We didn't want any other parents to go through what we were going through, which was sheer hell at the time. It turned our lives upside down. It fragmented our family. It was, as you can imagine, extremely challenging to deal with, and still can be sometimes. So we set up a fund in James's memory, and we learnt a huge amount about the space of suicide prevention and what's going on and what isn't going on. And we started to fund projects, and I lobbied with other parents. I was very fortunate to be introduced to other parents who had lost children in a similar way. And we lobbied and we made a huge noise, and we tried to get suicide prevention sort of into the open, shall we say. And I think to some extent we have succeeded, which is great. But all the time I was reflecting on the experience that James had had whilst he was seeking help up in Newcastle. And it wasn't a good experience. It wasn't helpful. I mean, I just kept thinking, what would have been the right sort of service for James? What would have been the right intervention? What would have hopefully saved James? And I came up with this idea of a very sort of calm, peaceful, non-clinical in appearance environment, but manned by trained therapists. So you could get the best therapy, the best help you wanted, which would be free, but you would be in a setting that valued you and respected you when you were feeling at your lowest. And so I came up with this vision of James's Place. And the vision became a reality 4 years ago. In 2018, we opened our first James's Place in Liverpool. And James's Place is for the highest risk group, which is men in general. So we only see men. And I think in the previous slides, it didn't say that men are 3 times more likely to take their own lives than women. And so it still remains the biggest killer of men under the age of 45, 50. So we set up James's Place, and our intervention, as you can see on this slide, is we do our intervention with the help of cards. We've created sort of an intervention called Lay Your Cards on the Table, which I think appeals to men. It's quite a sort of male, how can I put this? There are probably a lot of men on this webinar, but men, and I hope you don't mind me saying, but I think men find it very hard to articulate their feelings. And so what we try to do through the cards is we have thoughts and feelings and sort of coping strategies and on the cards, so that the men who come in to see us, who find it really struggle to say how they're feeling, they can lay their cards literally on the table, as you can see there. And I'm happy to say that this is working very well. And since we opened, we have helped. And if it's not being too bold to say, I would say we have saved over 800 men. So future plans for James's Place. Next slide, please. The building and the lovely view you can see at the back is our next centre in London, in the City of London. We found an extraordinary space that has this piece of green land, which isn't ours, by the way, but we can look onto it behind us. And we are opening that, our second centre, very, very soon. And I think you will hear about it very soon. We also have plans to open. We want to become a national charity. We're a small charity with very big ambitions, and we are going to open other centres in the northeast and hopefully Birmingham and Bristol within the next 5 years. So we've got a large appeal about to happen. But the reason that I'm on this webinar really is to talk about what it's like to work with people who've been bereaved, people like myself. So can we go to the next slide, please? So I just wanted to say that bereavement by suicide is very, very sort of complex because of the nature of suicide, because of the fact that as a parent or a loved one, you are left with all these unanswered questions, and there's no closure because you never get to say goodbye. And so, you know, above and beyond all the sadness and loss that you're feeling, you have all these other sort of really complex emotions such as feelings of guilt, feelings of rejection, an element of anger that this person has chosen to leave in the way that they did, and the sort of perpetual taboo and stigma that suicide seems to have, seems to contain. Next slide, please. So therefore, I believe if you're working with people who've been bereaved by suicide, you need to be very aware of the more complex nature of a suicide bereavement. And perhaps it's important to verbalize that you understand the complexities. So my recommendations, yes, don't tell a bereaved person that they'll get over it and that time is a healer. I think I found both those comments quite patronizing, and we all manage our feelings in our own way and own time. And I would say that perhaps it's more appropriate to say that we learn to accept it and we learn to live with it, would be my take on that. And choose your words and terminology carefully. Don't talk about committing suicide, rather that the person took their own life. It is not a crime to take your own life, but the word committing implies that it is still. Next slide, please. Don't avoid talking about the person who's taken their own life. However painful it might be to talk about them, most people want to keep that person's memory alive. And by mentioning their name and by talking about, the good stuff, when you're ready for that, it's all a part of the process of grief and acceptance of the loss. So don't shy away from it, even if it feels awkward. Next slide. Listen, 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 be present, and hold that person close, because they're in unimaginable pain. I would say, when I say hold that person close, you don't have to hug them furiously, but hold them close metaphorically and really listen to them and really be present, because you need to absorb what they're going through. Next slide, please. This is hugely helpful and really helped me, as I think I mentioned earlier, introduce them to other people who've been bereaved in a similar way. As one parent said to me once, we are members of a club that no one wants to join, which is sadly true, but there was a great solidarity in meeting other parents, and I really felt wholly understood by those other parents, and I hope they did by me. So I would suggest that. Next recommendation, please. Next slide. Suggest healthy coping strategies. And these aren't, kind of health NHS coping strategies. These are just normal ones that I would recommend, perhaps. So long walks, yoga, connecting with nature and animals, exercise really helps you in a very positive way, because it releases endorphins, which make you feel better. And I feel that animals provide great comfort and love, unconditional love during these difficult times. So those would be two personal things I would suggest. Next slide, please. And understand that those bereaved will also feel anger. I think there's certainly a stage and a phase where one feels anger that the person left in the way that they did, leaving your family so fragmented and your future so unsure. And also you feel guilty that you didn't save them. So there's a sort of anger towards yourself. So just understand that that is probably an emotion they will feel, the bereaved will feel. And then finally, and this is very much from my own experience, and it doesn't apply to everyone, but it's setting up our charity in James's name and memory has been a hugely positive and meaningful experience for myself and members of my family. Creating something so positive out of something so negative has been very healing, and keeps the memory of James alive and intact. So, and on that note, to find out more about James's Place, which is our charity, please visit our website, which is there.
Karen, are you there? Hi.
Hi.
Okay, so I'd just like to introduce Karen Lascelles, who's a consultant mental health nurse, and is going to talk has done a lot of work with people who have either been bereaved by suicide or who have experienced self-harm or attempts at taking their own life. So Karen, over to you.
Thank you. I have had a few messages saying my internet is unstable, so do let me know if I freeze. Hopefully, fingers crossed, I won't. So thank you for having me, and thank you to Linda and Claire for sharing those experiences. I'm not an expert in co-production, but I've been fortunate to work in various projects over the years with people with lived experience. And I can honestly say that it's one of the most rewarding aspects of my job. I mean, my ethos about co-production is that it starts in care. It starts at the moment I first work with a patient and their family around sort of working together to co-produce care, if you like. And obviously, nowadays we use the term very much around service design and evaluation and research and so on. So I just wanted to share a few of my experiences, really, in this field of co-production. So some of my work has been with the recovery colleges, both in Oxford and in Buckinghamshire. So in Oxford, some years ago, I worked with a peer tutor to co-design a workshop around self-harm. And I was involved in the first delivery of that, and latterly the peer tutor sort of took that forward, but as I understand it, it's a module that's still going. And of course, the beauty of being able to do that was that we were able to sit down together and spend some time understanding the experience as well as the theory, what helps and what doesn't help, so that we were able to give a shared perspective, really, to those that joined the team. The sessions. More recently, I'm working with Bucks Recovery College, and we co-produced and we co-facilitate a course that we call Taking Charge When Times Are Tough, which is essentially around the principles of safety planning. And it's using peer support really as a medium to explore coping strategies and share tips really to sort of pick up warning signs and get through difficult times. And it's one of my favourite things. We do it 2 or 3 times a year, and it's a 4-week course, and it's been really well evaluated because of its ethos, because it's surrounded, the peer support is at the heart of it. And I don't take a lead role in the co-facilitation. It's very much shared, and actually I often give the leadership to Haida, who's my peer tutor, who takes the main role. Now, interestingly, I was at a webinar not so long ago with an expert around safety planning who has done some fantastic work and educated probably quite a lot of us around safety planning. And I asked him what his perspective was around groups to think about safety planning. And he was like, oh yeah, maybe that's quite a good idea, but you do need to be careful about discussing certain things together in case people feel hurt or harmed in any way by the sharing of experiences. And I reflected on this in relation to the group at the Recovery College, and sort of thought, well, actually, it's the sharing of experiences that makes that as good as it is. And obviously, sharing of experiences needs to be done in the spirit of reciprocity and care and compassion, and wanting to help each other out. So you set those sorts of ground rules. But I thought, well, actually, we need to step away from a fear of talking about having come through difficult times, and actually draw on the experience of people like Linda and many others who have developed really good strategies that they're willing to share with other people. So these Recovery College modules are here to stay, and they're really valuable. In fact, we're hoping to develop another one linked to the men's groups at the recovery colleges around experiencing thoughts of suicide and strategies for coming through that. So we're getting braver, I think, and that bravery has come from working with people with lived experience, much more so than it's come from professionals, because people are saying it's okay, you know, we're not going to be too damaged if we're talking about things in the right way, with the right support. I do, however, think that it is important that that support is in place, because one experience I had of working with somebody over a number of years who was very active in lots and lots of sort of suicide prevention type endeavours, that included lots of training, it included getting involved in sort of guidance and strategies and stuff around the country, very, very active on Twitter, and lots of involvement. And very sadly, this person went on to end their life. And as when anyone ends their life, there's lots of questions. One of my questions is, you know, did we support that person enough in all of that work in the suicide prevention field, or were they left a bit to become oversaturated and perhaps overexposed, and was there some harm there? Now, I'm not saying that that was the case or it wasn't the case, but it's something that I've been left with, which has really made me think about how important it is when we invite people to share experiences and to share the perspectives that they have based on those experiences to help us improve care for others, that we need to make sure that support is there for people with lived experience. So an infrastructure to facilitate that is essential, crucial. We're very lucky in my organisation, Oxford Health, in that we have excellent service user and carer involvement leads, and they have huge networks of people, and they know the people in these networks. So I can go to them and sort of say, look, you know, thinking about this kind of project, what do you think? Do you think anybody might be interested in working with me? And they are able to introduce me to people who might be interested, and do careful introductions and make sure that the support is there to help us build up relationships, do the work, and make sure that there is support for people along the way and afterwards in case it is quite stressful. So that infrastructure, I do think, is essential. I also think that for us as practitioners, we need to be prepared for the possibility, in fact, the probability, that if we work genuinely in the spirit of co-production, we are going to hear things that make us feel uncomfortable. We are going to hear about experiences people have had where care hasn't helped. And we have to contain our responses to that, to stay present in the person's story, or their perspective, particularly because it's the perspectives that come from the stories that help us change care and improve it. So we need to hear things that might sometimes be upsetting in order to properly listen and properly be present there. And to that end, you know, we talk a lot in mental health and nurses, and that reflective practice is important when working in co-production as well, to make sure that we are not erring into tokenism. I think there's a risk of that if we're not careful. That's why we need the infrastructure to challenge us to make sure that we don't. So having one person with lived experience around a table or in a committee isn't co-production. Co-production needs to be equitable. There needs to be good weight of lived experience provision alongside the sort of professionals and experts and academics and so on, in order to really generate good ideas and come up with good outcomes. You know, thinking about that in relation to our suicide prevention strategy, we've just sort of reviewed, or started a new one really, refreshed it, and this time we've paid much more attention to co-production. So we have a steering group, and then we have work streams, and the steering group has a number of service user governors and people with lived experience in it. We've invited a co-chair with lived experience who we're hoping may join us, and the work streams have co-chairs of someone with lived experience alongside a clinician with interest in that area. And the objectives within those work streams are shared. They're generated from shared discussion. So Linda talked earlier about language, for example, and one of our work streams is around access and inclusion. And this was very much driven by the service users on the group who talked about our poor use of language sometimes. Think the traps people fall into by using things like take responsibility for yourself when somebody's struggling. Linda and I have had lots, to follow up on those thoughts if that's what you want to do. We need to be challenged about the language that we use, and the only way we're going to be effectively challenged is by really listening to those with lived experience. So I have high hopes for our strategy around that. Training is another area where lived experience is so important in delivery, but also in thinking about designing the training. What messages do people want to get across, and how can we manage that? In an ideal world, I think all training would be co-facilitated. Again, I've co-facilitated some training with Linda, and it's always 100% better than any training I do on my own, because whatever I may say, Linda might give an experience about why that's the case, or might challenge, some of the assumptions that we make as clinicians. However, sometimes we're a massive organisation and we have lots of mandatory training, and some of that is around risk assessment. Going back to my point about overexposure and the risk of somebody just doing things so much that it might become difficult and might have ill effects. We use a lot of film. So at the moment, I've been involved in doing some film with service users and carers and people bereaved by suicide to inform various training activities we have. And I have to say that, again, it's always the best bit of the training. It's always the most positively evaluated aspect. And I think that's how people learn. So I think that we also need to think about sort of co-production in relation to staff, actually, as well as service users and carers and people bereaved by suicide. An example of this is some research that we've done where we surveyed staff around the impact of a death of a patient by suicide on them, and found that lots of people struggle immensely and sometimes feel quite blamed by the scrutiny that takes place, whilst understanding that review and investigation and an element of scrutiny is essential to make sure that our carers are as safe and excellent as possible. So we developed a resource for clinicians around that impact. So the principles were similar to Help Is at Hand that lots of you will be familiar with, and certainly Clare was very involved in the review of that in 2015, which is a booklet for people bereaved by suicide. So this more recent booklet for staff is around similar to Help Is at Hand, really, in principles. And if anyone would like a copy of that, then I can share it. The one that's in existence at the moment is for psychiatrists, but actually it's relevant to any mental health professional. But following a second survey, we've developed one for all mental health professionals that is towards the latter end of design now. And that research group was made up of people with lived experience. So I think what we need to be doing more of is having research groups with people with lived experience of self-harm, of suicide bereavement, very much as part of the team in terms of designing research, but also delivering it. And PPI is a big thing in research, and there's lots of people who are really happy to contribute to that. And then my last point was, I think really my message and my learning is whatever I do. So I do lots of stuff like webinars and developmental stuff, education stuff, training, and I've kind of learned to never embark on anything without thinking, how can I do this with somebody with lived experience? Because without doubt, it is always better in that sense. So quick example is a webinar that we had last year, and it was to do, we had a series of them. Linda was involved in some of them, and one of them was actually with a young person. So we presented some research that people have done around mental imagery, and how when people sometimes experience mental imagery when they self-harm, that perhaps that self-harm is more suicidal in nature. And so, you know, this was a finding of the research. It's important stuff. But what we noted is that sometimes clinicians are frightened to ask certain questions, and asking the question around mental imagery is one of the things that they get anxious about. And we also know from research, sadly, that when clinicians get nervous and anxious, sometimes they just don't ask. So we had a young person involved in the webinar, and we asked her the question. And she said, well, in my experience, the most helpful thing was when I was asked, how do you experience your thoughts of suicide? How do you experience your thinking around self-harm? I wonder if you could help me understand, so that you know, I can properly think about what it means for you and how it feels for you. And you know, that's a simple thing. And certainly in my practice, and I'm at work today, I've seen somebody already this morning, these are questions I always ask now. So back to the language, the questions, to make our practice as good as it can be, we have to work in collaboration with people with lived experience. It can be so rewarding. So sorry if I have exceeded my timescale, but thank you for giving me the opportunity.
Karen, thank you so much. A really important perspective on a whole range of work that can really be improved by making sure that we have listened and understood the perspective of people with lived experience. So thank you very much, Karen. And we've just now got the opportunity to talk a bit more about and to answer any of the questions that people put in the chat. And there's a question about what it might be like to return to work or return to a sort of more social space after either having an experience of being bereaved, or an experience of self-harm, or trying to take one's own life. Does anybody have any reflections on what might have helped when you come back into a sort of more social space or a workspace after really difficult experiences?
I think what I found out is when I've gone back into a place after I've either self-harmed or actually thought of suicide, that people have ignored me, and they've ignored what's happened, rather than sitting talking about it, because I would have quite happily have spoken about it and spoken about, you know, that I'm struggling, which might have helped. Having more people know about it might have helped me not maybe try something else out in the future, had more support from people. But yeah, it has been difficult for me returning back after an episode.
Mm-hmm. And that it seemed to chime very much with what you were saying, Claire, about, you know, people not saying stuff.
Yes, I think actually, funnily enough, I remember speaking to a friend whose son had recently died, and she said she went to, I don't know, to a dinner or to something, and she said that her hostess didn't mention her son's name once, and it really offended her. And she said, I found it weak. I found it, she was appalled, actually, and she just said, you know, it shows how incompetent her friend, she just said, I felt my friend was incompetent, and it's really affected my relationship with her. So I think it's, you know, I think some people do find it really awkward. They don't know what to say, but just be brave and just obviously mention that person's name, because the person who's bereaved wants to keep that memory alive, that person alive.
I think it sounds, it sort of brings in some of the things that Karen was saying, that actually, you know, that even professionals find this subject hard to talk about, hard to ask the questions about. So it's not just friends and family, it's that all the way through into professionals, that this topic of all topics in mental illness or mental ill health is particularly difficult. And as you were saying, Claire, not necessarily with a sort of a history of mental ill health beforehand. It's something that suddenly happens, which makes it particularly hard. And Karen, did you have any other sort of reflections about that sort of, what can people do to I don't know, to be more present, to be more able to have these conversations?
I think I've just put something in the chat, by the way, a link to a booklet called Finding the Words that is designed for people who are supporting someone who's bereaved. But certainly I've gone into workplaces before when people have perhaps felt a bit anxious, as you say, Claire, when someone's coming back and they've been bereaved and they're saying, oh, I don't want to say the wrong thing. So and they found it very helpful, it's practical. But I think it reinforces the need to do co-production and to have people with a lived experience involved in sort of training and service design and so on. When we set up our local, or our regional rather, suicide surveillance system, which is a system where the police manage, and it's about having a real-time oversight of deaths that occur in our region, and it's about ensuring that families bereaved receive early signposting to the right support. When we set that up, we were nervous, and we were nervous about what's the right thing to say, what's the right thing to write in these letters, developing leaflets and literature, how do we get it right? And because we had people bereaved by suicide with us, helping us and guiding us, they were able to help us with that language and also challenge us when we were talking about evaluation. And we were again nervous. Well, surely we can't phone somebody up and say, how did you find the service? Is there something that we could do differently or better? And we were nervous about doing that. And the people who were bereaved said, the worst thing that could happen to us has happened. And probably if you phone somebody up and ask those questions sensitively, they're going to be glad that you're making the effort to make sure that people are supported when these terrible, terrible tragedies occur. So we were challenged in a really helpful and supportive way.
And it does sound like, actually, when people are, genuinely anxious about not saying the wrong thing, that actually not saying anything is the wrong thing, rather than maybe being slightly sort of it is difficult to find the words, but actually some words are better than no words. Is that a reasonable description of the situation?
Yeah, I would say, and I think it is really hard. I think it is genuinely hard for friends, family, anyone connected to, they just don't know what to say, what to do, because it is the worst thing. And that's why it was so great when I met other parents, because I just suddenly felt like we were speaking the same language. Whereas with people, that I'm very close to, I felt I was on a different, literally I felt I was speaking a different language to everyone. And it was really hard, because then you feel very isolated in your grief, and because you just don't think anyone gets it. And that was hard. So for personal experience, for meeting other families was probably one of the best things, most helpful things for me. And there are lots of books out there. I was given, I've got a shelf of books upstairs. I could start a self-help library, I think, of books that I was given. But actually the best book anyone gave me is a book which I have I carry it everywhere. And it's here. It's called Man's Search for a Meaning by Viktor Frankl. And it is an absolutely brilliant book about Viktor Frankl, who was an Austrian prisoner of war in Auschwitz. And it's all about our response to situations, and it's about the fact that suffering is inevitable, and it's about how we deal with it. And I found that this is my Bible. I take it everywhere. So have a read. For those of you who haven't, definitely worth a read.
I have to say, Claire, I absolutely agree. It's one of the very few books I've read more than once. The great advantage is it's a small book, so it's possible to do that. But it shows the strength of human fortitude, of the capacity of people to deal with absolutely terrible events in their lives, and to both find meaning in the small things in life when actually the big stuff is awful, and how important that sort of small stuff can be. And it can sound very trite and very sort of, oh, well, just take joy in the sunset sort of thing. But actually, there is something very real about taking a moment of the present, of the things that actually are there, rather than always try and deal with the big stuff which may be outside our control.
100%.
Linda, I was just wondering, just talking about that sort of, talking to other people who have had the same experience or similar experiences, and your role as a peer support worker. Can you just tell us a little bit about how you got involved in doing that, and how that's been for you, actually?
Yeah, I got involved with that, well, through lots of other work that I'd done beforehand. And I saw the advertisement for it and I thought, wow, something that I can give back through my experience, that I can give back so that others don't have to suffer the way that I did, and maybe have help staff to understand what the feelings were, what the emotions were, how I presented, why I presented like that. So yeah, that's the reason I got involved in it. But also going throughout this type of work that I've been doing for the last 6 or 7 years, I got involved with, it was a nationwide project where police officers actually go to families that have had someone commit suicide, but they have, it's the aftercare and support that was lacking, and that is starting to be a bit more now. And it's what to say with people, how to say it, and the language as well that's used. And it was a really good project to get involved with, because it was peer support or peer workers, as well as families that had bereaved, people that have committed suicide along the way, and having, because sometimes there's not an understanding of why somebody has done what they've done, but having somebody like myself explain the feelings I had sometimes helps somebody that has, lost somebody in that particular way. And although it's not the same experience, it does give a bit of help knowing that there might have been something similar to what I've gone through.
Okay. That makes a lot of sense. I mean, we talked quite a lot about the sort of the actual words that people use. I mean, are there other things that I think Linda, you sort of, you talked about people using particular language, and and I think, Karen, you mentioned responsibility, taking responsibility for things. And I mean, are there other things that you think are important in terms of the sorts of ways that people ask questions or talk to you or to other people? Because one of the questions that's been put in the chat was actually how to help find out how people feel if they've been bereaved, or indeed if they have been through a self-harm situation. So what sorts of, how would you open the questions? What sorts of things would you ask someone?
So sorry, Karen.
You go ahead. No, go. You go first.
I was going to say validation is the first thing. First thing is to validate the feelings of either somebody that's lost somebody or somebody that's gone through it. And I've always said validation, that it is an awful or traumatic thing that somebody has gone through. And it's also the way you speak to somebody as well. It's the gentle, caring approach, because you are caring about that particular person. You know, you're not there just to be nosy. You're there because you care. That is my main thing, is validation.
I think that's a really interesting, that idea that actually one's not being intrusive and nosy by asking these questions. One's doing it because it's coming from a place of care. I think that's you can quite see how what somebody might feel, that actually I can't say that because actually isn't that, you know, that too intrusive. Yeah. Thank you. Sorry, Claire.
No, I think what Linda's just said is very true. I think sometimes, I mean, I've been to speak to other bereaved parents myself, and you know, even though I've been through the same experience, there is that feeling that I'm being intrusive, and you've got to understand that their grief will be different. There's very different ways of processing it, and I think it's very important, like I said, it's not, you mustn't preach. You can say how you dealt with it and your coping strategies, and, you know, your books or your exercise or your beliefs, religion, whatever you have, but that won't apply necessarily to everyone. So I think it's about listening to that person, and if they ask you, well, how did you cope, then saying it, but just really being there to listen to them, not to tell them how to do it, but and to understand that everyone's situation is very different and everyone has a very unique way of processing their own grief and a unique time.
I think there's the sort of thing that I try very hard not to say, because I know that when people say it to me, it doesn't always work terribly well. It's that sort of I totally understand sort of approach. And actually, you know, what I've heard you say, Linda, is it's about validating what that person has told you, which means that you have heard it because you can say it back to them, and that actually it is their particular way of saying or understanding or feeling, as opposed to I understand it because I've been there. And it's you and I think, as you're saying, Claire, that, you know, even if you have been bereaved in similar circumstances, it isn't exactly the same for everyone. So it's about acknowledging both being present, but also that actually this is somebody else's experience. So it's not the same for everyone. Sorry, Claire, go.
I always get asked the same question. Sorry, I always get asked the same question, which is, how did you get up in the morning? And I always find that quite a weird question, because obviously, and I said, well, I had to get up in the morning. You know, I have other children, I have a life, I have work to do, I had, you know, a house to run. I understand the question, obviously, but, you know, you have to get on. You have to, thank God I had a life, you know, thank God I had other kids. I was lucky in that respect. I think it's important to, as somebody bereaved or someone really struggling, you know, you've got to kind of set goals for yourself each day, because if you don't get up, you're just going to get worse. So you just have to try as hard as you can to do the normal stuff, have your normal routine. Just slowly come to terms, very slowly come to terms with what's going on.
And that's a bit similar. What I do in the role I do now as a peer support worker is actually try and help somebody to find the goals of getting up, of actually moving on, so that they're going to look at ways slightly differently to the way they look now. But it's always trying to help somebody to find their own goals.
And that sort of brings us on to there's the question in the chat that somebody's asking about how to help someone manage their feelings if they are feeling suicidal. And so Karen and Linda, do you have a sense of, you know, of what sorts of things do you think are useful there?
I think it's hard to give a blanket answer. because each of us experience things in our own way. I would agree with Linda, validation is the main thing. Just sort of touching on the previous point in terms of these conversations, I think my top tips, the things that I've really learned, are probably three things. One is sort of around radical presence, where you can be immersed in someone, sitting alongside somebody else in and be there alongside that terrible distress, and bracketing your own emotions and being properly present for the person. Another is, you know, I do quite a lot of work with people recently bereaved by suicide, and one learning that I learned from someone who'd been bereaved is, don't go around and say, how are you? It's so tempting to, because it's what we do. How are you? But it's a platitude. And you know, I have made that mistake, and you know, how do you think I am? I don't even know how I am. So one of my learnings is that I don't do that now. I will go and I will, you know, I don't have a set way that I'll start a conversation, but it's about being alongside, you know, conveying, you know, that you're sorry, or that you know, that this is a terrible time, but not starting with how are you. And I find that I can't even say, well, what else then? But it's a better way to get alongside and reach that really important place of radical presence. And I think the other thing, and when we're working with somebody who perhaps is experiencing suicidal thoughts, this is helpful, is accept the possibility you might be wrong. So if you're trying to reach a shared understanding, which to work effectively with somebody, that's what you need to do. You know, I might be wrong, but this is what I'm thinking based on what you're telling me. You know, and what are your thoughts about that? Because then I've got much more chance of learning how it really feels for that person, and what really might help them.
I think it's very interesting, and I suspect applies not just in a professional capacity, that sort of absolutely, you know, I've certainly been in situations where, you know, friends have their response to whatever is going on is to tell me what to do, to give me advice, you know, but to not actually just be present. And that is the bit that you really need. I think I was very struck, Clare, by your sort of, you know, that sort of, you need to hold the person, but that doesn't mean to say literally, but there's something about just being there. And that might be being there in silence. I mean, it might not require lots of words, and that's true both professionally and in, you know, in everyday life. Being alongside as opposed to looking down, I think you talked about, Linda, and how important that is. I'm just
and I think sorry, just
yeah.
Can I just say one? Sorry, just
no.
Karen was just saying, don't say how are you, but you could say how are you coping. I mean, that might get the same response. Well, how do you think I'm coping? You know, but it's sort of acknowledging that you're having to cope with something that's really hard. And so it's asking that question, but in a slightly different way, possibly.
I've just we've got another sort of 6 or 7 minutes, and I know that a couple of you need to leave sort of for something at 1, so we're going to probably cut a little bit out of the sort of, we'll finish just before 1. I mean, one of the things that sort of came up in something that Karen was saying is that actually there is a very definite impact of both suicide and self-harm on staff. And I was just wondering, you know, if you have any thoughts about how do we support staff in this situation as well?
Yeah, I think the most important thing is to say that we must, and the impact on staff can be quite profound. You know, into lots of feelings of guilt. What did I miss? What did I do wrong? I shouldn't be in this job. You know, it's my fault. And you know, then of course people do need to undergo internal investigations and inquests, and that may take place over months and years, and might be named in the press. We've had staff who've been named in the press following an inquest when all they've done is given some evidence. you know, but the way that the newspaper is framed, they don't intend to be inflammatory, but you know, I had a staff member who said, you know, I've lived in this town for most of my life, and my name is now in the paper linked to somebody's death by suicide, and I go and see other patients, they might have read it, they might think that it was my responsibility. People have gone up to my children at school and said your mum was in the paper because of this. You know, we need to sort of extend sensitivity to staff. And this wasn't, you know, the case was that nobody was found to be culpable, but sometimes people can feel that. I hope I'm still here, you've frozen up a bit. The Royal College of Psychiatrists has developed some guidance for organisations around supporting staff, and I think this is going through what I understand is the final stages of sign-off and will be distributed. And it is things like having a lead within the organisation who specialises around suicide and supporting staff, providing group support, individual support, signposting to counselling, but there's no one size fits all, in the same way there's no one size fits all for somebody who's been bereaved, or somebody who's you know, experiencing suicidal thoughts. You know, and making sure that investigations and reviews are done sensitively and reflectively, and not with blame.
That makes sense. Yeah, Linda.
I think I've had something happen to me being a peer support worker in my role, and it's been able to have somebody that either your manager that you'll really get on with, or somebody that you know that can support you in the way you need to be supported. But one of the persons I contacted straight away was Karen in the particular thing. So it's knowing who you know that understands what you're going through.
That makes a lot of sense. Claire, have you had any experience of supporting staff?
I haven't. I know that the staff at James's Place, obviously, they're dealing with men who are acutely suicidal. I know that obviously there is support systems in place for all of them. No, personally, I haven't. It hasn't really, you know, it was, I guess it was very awkward, the whole experience up in Newcastle, and I just always felt it was just best just to leave it behind me. And you know, it's in, you know, in hindsight, it's very easy for me to say, like, you know, that obviously James had said he felt suicidal. He shouldn't have been made a low priority, and this has been brought up recently in the press by another parent. So it's something that it needs to be. This is a learning process, I think, for dealing with suicide. But I think if somebody says they want to take their own life, it is not a low priority. It is an extremely high priority, and that's what needs to be understood.
Okay. I'm just keeping an eye on the time. Is there anything else that people that any of you would like to say as just a sort of final thoughts? Karen?
I guess mine would be, you know, we all strive to provide the best care we can, and the way to do that is to work in partnership with people with lived experience. Mm-hmm. So co-production is a must, it really is.
I 100% agree, because it is not possible to know what it is like, even if you have had a similar experience. And certainly when you're sitting there in your professional capacity, some of that personal experience that you may or may not have had disappears because of the nature of the role that you have. So you absolutely have to do things in partnership. Claire or Linda, any final thoughts? You're not obliged to have final thoughts, incidentally.
No, I would just agree with what Karen said. I think it's really important, you know, my lived experience of what I've been through, you know, I'm not qualified, but that qualifies me in many ways to help.
Yeah.
And you know, my mission through James's place is to help men like James get the right help. So if I can help bereaved parents as well, or Karen in her role and other staff members, I'm here to help.
Thank you.
I think for me, I always say validate and listen and just be there for somebody.
And I think that for just having it listened to the three of you speaking, then that's really the sort of core bit of this. It's sort of, don't avoid asking. The wrong thing to do is not ask, rather than worry about getting it absolutely perfectly right. And that being present, sitting alongside rather than looking down on someone, and holding that person's holding some of that pain with them is all the things that all of us could do, whether we're sitting here as professionals or sitting here as family members, and to acknowledge that everyone's experience is different, and that you need to validate and hear their experience. And that I think you Karen used the word like sort of radical presence, that there is something about that sort of, it's not just a sort of I'm going to listen, it is I'm really going to listen, and that takes a very different sort of approach to listening, because we can our ears work all the time, but there's a very big deal difference between the words having somehow gone in and actually genuinely hearing and listening. So thank you all very, very much. Powerful stories, extraordinary bravery by saying it all, and so thank you very much. And just so that people are reminded, I'm just going to share my screen again, and if anybody needs to talk to someone, then please make sure that you do, and these are the phone numbers and emails. Lucy will be sending out an evaluation form. We would be really grateful if you could fill it in. This helps us to make sure that what we're doing makes sense to the people who are listening, and improves the workshops and webinars. And we're also looking for a new series to run next year. So just to say thank you to you all, and thank you in particular to our speakers. So have a nice rest of the day.